So we've got about 13 minutes left. So we will begin the Q&A. And if you'd like to ask Robert a question, you can raise your hand in Zoom. The instructions are in the chat. So Robert, first of all, how would people follow your work if they're interested in following what you do?
Well, obviously I did write a book called Anatomy of an Epidemic that sets out a lot of this. I also co-wrote a book called Psychiatry and Influence that talks about this corruption. But ongoing, I do run Mad in America, a website. And there you find a couple things. You find almost daily science reports that aren't promoted to the public precisely because they contradict conventional wisdom. But there'll be reports on long-term outcomes with antipsychotics, for whatever disease. There'll be articles about whether these are validated disorders. And you also will find on the website resource pages. So you can go on menu bar drugs, and then there'll be a drop-down menu, antidepressants, and you'll get a nice long but succinct review of the literature I presented today for stimulants, for antidepressants, for antipsychotics, and links to the studies where you can then access the studies themselves.
Great, thank you. And in the time that you've been working on this, because it has been some time, has things gotten better? Do more doctors seem to be skeptical of the paradigm that they have been educated in and have been themselves promoting?
That's a great question. There is more skepticism. There is actually a lot of acknowledgement within the research community itself that this whole model did not pan out, and that outcomes, if anything, they haven't improved, and if anything, have worsened. Even Tom Insel, the former NIH director, said that. The chemical imbalance theory, at least in the research community, has completely collapsed. There's more and more acknowledgement that long-term outcomes are poor. A man named Nasser Ghaemi, a very famous psychiatrist, said we should only be using these drugs short-term. There's no evidence they provide a long-term benefit. So there is more skepticism towards that disease model story. And that is leading many people to be actually more cautious about prescribing drugs, and also to be, at least some, more supportive of people who want to withdraw from psychiatric drugs. So that is changing. The narrative has changed within the research community to a large degree, and there are many practitioners who are changing. However, the great majority of prescribers are still following that conventional model, using drugs right away as first-line therapies, antidepressants, antipsychotics, and not supporting people when they want to come off, and seeing any sort of bad outcomes as due to the disease and not to maybe the drugs worsening problems. So we're at this moment where a paradigm shift could happen. You have the World Health Organization, you have the United Nations saying we need to change this thinking. And you've had a long-term grassroots saying like this really isn't working. And the research literature now is just filled with studies. You can come on to Mad in America that show these aren't validated disorders. The whole genetics search hasn't panned out. The chemical imbalance story didn't pan out. We really don't know. There are no biological markers. Even short-term symptom remission is not particularly good with these drugs. And more evidence showing that long-term, the best thing is if you can become unmedicated. Recovery rates are much higher. Now, not everybody can make it to that end, but that's what's showing up in the research literature constantly now. Yeah, it's so much more robust than it was in 2010 when I wrote Anatomy of an Epidemic.
Oh, that's good to hear. So no, that's the profession itself. What about the general public and their skepticism, and especially in light of things like the opioid epidemic, where I think that I don't think there was any sort of defense, that was that the public bought. It was a little bit hard to obfuscate that type of thing.
So here's what happened with the public, the opioid epidemic. Everyone knows heroin's bad for you, right? So they were already primed to think that a drug that acts like heroin is going to be a bad drug for you and can cause overdoses. And when they say it, and it's pretty easy to say, oh boy, they lied to us when they said it wasn't going to be addictive. So the public was prepared to accept the idea that, boy, we were bamboozled. The problem is that same skepticism has not been built up around psychiatric drugs. And the reason is, you can go to New York Times and not find any of the story I just told. You can go to the Washington Post and you will not find the story I just told. They just there's for whatever reason, the mainstream media is still cowed by the larger psychiatric association story about, yes, these are diseases of the brain. ADHD is a discrete disorder, and the drugs are safe and effective. And for whatever reason, and I do not understand that, and I'm a former newspaper reporter, they just will not report on all this literature that in essence undercuts the narrative that we have organized our thinking around. And I don't know why, but it may be that a lot of people, editors and all, they've organized their life around that story, and they're loath now to cognitive dissonance sets in to even consider information that counters it.
Well, and we've had people talk on this during this conference that the fact that there is, that the pharmaceutical industry is advertising through these mainstream channels. They're not just paying to advertise, they're paying to control the narrative of the companies they're advertising through. What are your thoughts on that?
Well, basically, that's true. I mean, yeah, they say there's a wall between, the business aspects and then the editorial functions. But you've got to look at what happened to media, right? Let's say newspapers. They lost their classified ads. They lost their display ads, and subscriber fees can never cover it. So, any sort of, and then TV, they need, so in other words, pharmaceutical funding of media, magazines in particular, and TV. Go turn on your TV, there's pharmaceutical ads. Yeah, they have a hard time like cutting off that lifeblood. It makes perfect sense in this from a financial point of view. So yeah, pharmaceutical companies are making themselves indispensable to much of our media, which does prevent them from going after, say, psychiatric drugs or other things that may not be effective. And by the way, as I was on last night with John Abramson. Pharmaceutical companies are also funneling money to the research journals too. So they're not very eager to actually promote findings that are contrary to the sort of the marketing of these therapies. That's part of the problem. It's an information flow problem.
So we've had various experts talking on the concept of standard of care, where there's a protocol that doctors are either suggested that they follow, or that they are forced to. Like in cancer, you very little leeway in how you treat patients. Is there a strict standard of care with how to treat these patients that doctors are not allowed to deviate from? Like, are they, if someone is psychotic, are they pressured through a standard of care to prescribe this medication, or are they just bought into the model?
Well, many, of course, have bought into the model because they went through medical school and they were basically trained in this model and trained to think about these are safe and effective drugs and first-line therapies. Plus, that's what psychiatrists do now, right? They prescribe drugs. But with evidence-based medicine, if you have people saying these are the guidelines, this is what you should be doing. And remember, I went through who's setting those guidelines? People who are receiving money from drug companies. And they also have guild interest to promote. Once you have those guidelines, if you vary from the guidelines, like you don't give antipsychotics to a newly psychotic person, yeah, you're opening yourself to a claim of malpractice. You are, because you're seeing it's not providing standard of care. And there was a famous case in the 1990s with a depressed patient who wasn't given an antidepressant. And then he sued saying, I should have been given an antidepressant. And basically, there was this sense that you could be sued if you didn't follow standards of care. Now, often those suits aren't successful because doctors are seen as having leeway with their clinical use of things. However, if you're providing care in a larger system of care and you all of a sudden start challenging what everybody else is doing, you're going to be pushed out of that. They're not going to tolerate these lone wolves, so to speak. So this is part of the problem, that we actually do have an, quote, evidence-based medicine that is generated basically by the drug companies and promoted by people either working for the drug companies or promoting guild interests. And they're the ones that develop protocols. They're the ones that develop standards of care. And yes, you're a medical professional. It's really hard to break from those standards of care. Now, what's interesting, for example, the the NICE, National Institute of Clinical Excellence in Britain, is saying don't use antidepressants as a first-line therapy for mild to moderate therapy. And that's partially because the pharmaceutical companies don't have the same influence they have there as they have in the United States, where you can advertise direct to the public.
So, and I realize that you're not a medical doctor or psychiatrist, you're a journalist, but are you comfortable in suggesting what the protocol is for people who want to wean off these drugs? Not that we're suggesting anyone should without the care of their doctor, but is there a protocol that you're aware of?
Well, actually, this again is now coming from the UK. Now, there's something called a Maudsley guideline. Now, Maudsley books are seen as very well referenced books, okay? And for guiding medical care for a long period of time. And Mark Horowitz and someone else who was quite famous in UK psychiatry put together this textbook called The Maudsley Guidelines to Drug Withdrawal. So you are starting to see that tapering, antidepressants, or antipsychotics can be an accepted practice. And there are guidelines for doing it slowly. And if you follow those guidelines, as a professional, you should be okay, because in fact they have now been incorporated into guidelines to follow.
All right, so we have about a minute left. Are there any thoughts or anything that gives you optimism for what's going on in the future?
Yeah, I'm optimistic for two reasons. One, there is a growing chorus of voices saying this disease model has failed, we need to rethink it. That is up there. And when you have the World Health Organization and the United Nations saying we need a paradigm shift, that's a good moment of change. The other reason I'm optimistic, and there's a lot of grassroots we've had this thing for 43 years, it hasn't worked. There's a lot of people voting with their feet away from that model. And the other reason I have optimism is this: everything tells us that human beings are resilient. And then if you put them in different environments, you give them environmental supports, so many people can get better. Children can change their behaviors. And so part of the reason for my optimism is if we can have a paradigm shift that reconceptualizes this and says there's many pathways to psychiatric difficulties, but we know one thing: people are built to be responsive to their environment. And if we can create new environments around health, food, diet, sleep, social interaction, etc., we can have a system of care that will turn many of these problems back into episodic problems and help people, get their lives back together. Instead of what we do today, we pathologize people, tell them it's chronic, and that's what happens. They start seeing themselves as chronically impaired.
Great. Thank you so much, Robert, for all the information that you shared with us today. If we could unmute the audience so they can share their appreciation for Robert, please.
One-on-one.
Thank you, Robert.
Thank
You're my
you.
hero.
Thank you.
You've been my guide.
Thank you.